So thank you very much. Good day one more time. It's my great pleasure to introduce the contrast enhanced ultrasound webinar of today. So on behalf of the European Federation Societies of Ultrasound in Medicine and Biology, it's my great pleasure to start this webinar. It's really interesting for us in Europe to see the Asian experience in contrast enhanced ultrasound. As you probably know, EFSUMB is the leading, I could say, ultrasound society, has launched a series of webinars sponsored by BRACO. So this CEUS webinar today is the fourth one this year. And it's my great pleasure to start this webinar and to see the experience of our Chinese colleagues. And I will introduce the first speaker, which is Zhao. And the presentation is the role of CEUS in patients with primary liver cancer. So please.
Thanks for Professor Adrian. I'm Dr. Zhao from the First Affiliated Hospital of Zhejiang University. It's my honor to be here to share my experience about the role of CEUS in patients with primary liver cancer, HCC. As we know, CEUS has already been widely used in the world. In China, it also has been widely used in many areas, such as cardiac, thyroid, breast, but mainly in liver application and intervention procedures. In liver application, CEUS is a method for diagnosis of HCC, metastatic liver tumor, and benign hepatic tumor. WFUMB since 2004 has provided 5 editions for CEUS guidelines, and ACR also provides 2 editions of CEUS LI-RADS for clinical diagnosis. These guidelines introduce many information for correctly using CEUS. In 2011, CEUS was added in the first edition of Chinese Standard for Diagnosis and Treatment of Primary Liver Cancer. And in 2017, CEUS is recommended as a first-line imaging examinations in the diagnosis of liver cancer for the first time. And in 2019, the application scope was expanded and intraoperative CEUS was added. The microbubble of contrast agent is smaller than the red blood cell. 90% of the microbubble have a diameter less than 6 millimeters. So it's a pure blood pool contrast agent. Vascular phase is a key to diagnose liver lesions. From this picture, we can find the portal vein and arterial blood supply decreased from the cirrhotic nodule turned to be progressed HCC, and abnormal arterial blood supply increased. This is the anatomy hypothesis of CEUS findings. From the results of many studies, classic CEUS features of HCC include early hyper enhancement in arterial phase and with or without washout in later phase. And the size of HCC may be different. In small HCC, mostly homogeneous enhancement, and while in larger HCC, mostly heterogeneous enhancement. And some research found the enhancement model is related to the tumor cell differentiation. Chinese researchers reported the correlation between enhancement pattern and tumor cellular pathology. they found that CEUS showed the shortest enhanced time and clearance time in the low differentiation group. And last year, CEUS LI-RADS application in Chinese patients were reported in radiology, which confirmed the CEUS LI-RADS as an effective tool for qualitative diagnosis of liver nodule smaller than 20 millimeter in patients with high risk of HCC. And CEUS LI-RADS 5 could improve the specificity of HCC diagnosis. Now let's see some cases. This is a small HCC, and we found the homogeneous hyperenhancement in arterial phase, and in portal venous phase, we can see slightly washout, and in the later phase, we can see clearly heterogeneous hyperenhancement. So this nodule is wash in and wash out. We can diagnose this as HCC. And the case 2 is a large HCC. We can see the mass located in the right lobe segment 6, and is a heterogeneous mass in ultrasound, and larger than 5 centimeter. When we do contrast, we found the heterogeneous hyperenhancement in arterial phase, which is different with a smaller one. And in contrast CT, we can see slightly enhancement in arterial phase and clearly hyperenhancement in portovenous phase. So this is a difference. And in the later phase, CEUS found washout clearly, and the message diagnosis is HCC, while in contrast CT, no washout in the late phase, and misdiagnosed as hemangioma. The reason why is the same lesion has different image demonstration. Maybe the contrast ultrasound is real-time monitoring, and while the contrast CT is scan maybe too later or too early. Case 3 is a well-differentiated HCC. We found in the CT, we can see a low density area here, and in ISO enhancement in arterial phase. While in contrast ultrasound, we found the hyper enhancement in arterial phase. We monitored until the late phase. This nodule show ISO enhancement in the late phase, presented early enhancement and no washout. While in contrast CT, it is washout in late phase. After the surgery, the pathology confirmed it's a well-differentiated HCC. Case 4 is a poor differentiated HCC. He's 65 years old and right lobe nodule under the capsule. And we found the hyperenhancement in arterial phase and the washout very fast in 38 seconds. And in the late phase, it wash out very clearly. So this is different with well-differentiated HCC. And case 5 is a 55 years old male with hepatitis B for more than 10 years, and the tumor mark ALP is increased. And we found two nodules. The first is a hyperechoic nodule, and the big one, and then the second is a hypoechoic nodule, a smaller one near the gallbladder. And we want to know which one is the problem, which one is the HCC, because the tumor mark is indicated. So we injection SonoVue. In arterial phase, we found the first is a bigger nodule. It is hyper enhancement, and in the portovenous phase, it become hyper enhancement. It wash out, and in the later phase, it wash out. So the bigger one, the first hyperechoic nodule is wash in and wash out, and we diagnose is HCC, while the second nodule, it's a small one, and in arterial phase and portovenous phase and the later phase, we can see ISO enhancement and no washout. Then we do biopsy to confirm our result. We do biopsy, and the pathology results indicate hyperechoic nodule. The first one is HCC, and the second one is a smaller one, and hypoechoic nodule is a hyperplastic nodule. So we can see without washout, this nodule is benign, and washing and washout, the big one is HCC malignant. So when we do contrast to diagnosis HCC, we should focus on 3 points. First is we must know the clinical information such as AFP, tumor mark, and whether the patient has HBV or HCV history. The second, we must focus on the CEUS model. We must know the enhancement time and the enhancement intensity. The third, we should combine the CEUS with MR and CT when we found the untypical nodule. This is my topic presentation. Thanks for your attention.
Thank you very much for the presentation. Let me see if we have questions. So there is one question on the chat for case 3. The question is why there are differences in between ultrasound and CT contrast enhancement in the later phase.
Oh, that's a very, thank you. It's a very good question. And we know ultrasound contrast agent is a poor blood pool agent. It will not diffuse into the parenchyma of liver, while the CT contrast agent is different. When we inject contrast of CT in the patient, the agent will diffuse into the parenchyma of liver. So this is a difference, may result the difference in the later phase.
Okay, thank you very much. Can I ask you also a question just to stimulate a bit the discussion? When are you still doing liver biopsy? In which patients are you still doing liver biopsies? Because our oncologists are asking for tissue in a lot of patients. Are you still doing liver biopsy, or are you relying only on the information obtained by contrast ultrasound or CT and MR?
Yes, contrast CEUS can diagnose HCC in most of the patient or most of the nodule. And if the nodule is located in the safety location, and we can do biopsy safety, and we do biopsy before the surgery or before the ablation. And if the location is very dangerous and with high risk, then we will rely on the CEUS or CEMR to diagnose the nodule.
Okay, There's another question in the chat. Meanwhile, is about Sonazoid. If you think it could diagnose well differentiated hepatocellular carcinoma. So if you have experience with Sonazoid as compared to SonoVue.
I think I have done experience several cases of Sonazoid. Sonazoid may be helpful in the case of well differentiated HCC, because in SonoVue sometimes some cases is no washout, and while we can use Sonazoid, maybe some cases we can find the washout.
Okay. Because we don't have experience in Europe, so except Norway, where Sonazoid is approved, Sonazoid is not approved in Europe, so we only have experience with SonoVue. We cannot get it for examination purposes. Okay.
Okay.
If there are no questions, thank you very much one more time, and thank you for the great presentation.